Welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Don't forget to subscribe my channel and also please give your valuable comments. As we know, in the last class we are discussing about the obesity, especially we are discussing about childhood obesity and some of the causes, and also we have discussed the different types of definitions and different classes of obesity. And we have also seen the risk factor, and we have also seen the different triggering factors, and we have also got some of the syndromes, endocrinal causes which is responsible for childhood obesity. So today we will have the continued version of the same, and we will see when a patient of obesity comes to the OPD, what will be our approach and how we have to assess the things. Now, in the assessment, one of the main thing is history. Okay, you have to take the history. That history may be related to the nutrition. That history may be related to overnutrition. History may be related to sedentary lifestyle. That history may be even related to the family. Now, family history of obesity and family history of type 2 diabetes and family history of cardiovascular disorders and also the family history of cancers in the first and the second degree relatives of the family has to be understood very well, because all these causes will have a potent relationship with the development of obesity in childhood or in the adolescence period. Now we have to take the history of weight gain, of course, loss of weight or weight gain, both has to be taken. Now the recent weight gain and persistent weight gain, that has to be understood. Child is obese since the beginning, child is recently started getting obese. Now this is how we can differentiate between the nutritional obesity and the non-nutritional obesities. Now, age when child cross the 85 to 90th percentile of the body weight, that is also very important. At particular age, at what particular age that child crosses the 85 to 95 percentile in the BMI, we know that. So this is a starting point of the overweight. This is called as overweight. Then it leads to obesity. So at what particular age the baby has crossed this age, this is very important, because during adolescence usually the children usually gain the weight, and if the same has been happened in the early childhood, that is quite worryable. Age at which the parents notice and get concerned, that is also we have to assess at what particular age. Now you have to also discuss or take the history of medication or some of the iatrogenic weight gain. Suppose the patient is taking some of the steroids, patient is taking some of the medicine for endocrinal problems, patient has got also taking some of the protein powders which is available in the market. So all these history is also very important. Now growth and development of the child has to be taken properly. It should be assessed properly to rule out the syndromic causes of the obesity. We have got listed so many syndromic causes of the obesity also. So in that case, growth and obesity, growth and development history has to be properly taken. Prader-Willi syndrome and Down syndrome, so Blackbird syndrome. So these are some of the important syndromes which may lead to obesity. So in this case, the history, the proper examination of the growth and development, that is very important. If growth and development is abnormal since beginning, along with the weight gain, so then it is one of the a major clue for the syndromic presentation, along with the dysmorphic features and all those things. Now, other assessment that you have to do, you have to take the history of the sleep. What is the sleep pattern, whether he is following the sleep hygiene or not. Then history of snoring. Snoring, that is obstructive sleep apnea, is one of the major cause for the, or you can say obesity leads to obstructive sleep apnea as a complication. Then school performance, and especially what is the social behavior of the child also, whether he is introverted because of this obesity and all those things, whether he has developed some inferiority complex because of this obesity. So all these factors has to be assessed. Now attitude and willingness to make the changes. Now this is a very important thing. When a child comes to you with obesity and you want to do the treatment, and parents also want that you have to go for the treatment, now you have to see the attitude and willingness of the child, whether child is actually want to reduce the weight, whether child actually want to come out of this problem, or child is not at all worried but parents are worried whether this is a situation. Now unless and until child understand the gravity of the problem and the child understand the future complications of this obesity, it's very difficult to counsel the child. And once he understood the gravity of this problem, then it is very easy for the treatment. So involvement of the patient or child is very important. So attitude and willingness to make the changes. One person in the family is concerned and rest of the rest, for example, one person, mother is very much worried about his gaining weight gaining, but all the other family members are busy in eating the junk food and all those things, they are bringing the food to the home. So this type of attitude may not work. Okay, so not only the child, even all the family members of the all the family members, they should have a single attitude. Yes, something has been restricted means it should be restricted, nobody should eat it. So this type of attitude is very important, otherwise it's very difficult. Now we have to also go for the behavioral assessment. Okay, screen time, now this is very important. Screen time, American Academy of Pediatrics that recommends zero screen time for the kids below the 2 years. Now this is what say, below 2 years of the age, screen time is zero. No mobile, no television, no laptop, and no video games. Okay, screen time should be zero. And American Academy of Pediatrics says that after 2 years, the screen time should not be more than 2 hours. That means should be less than 2 hours. Okay, even after 2 years also, till school going age and all those things, even the school age. Okay, it should not, for any person, the screen time should not be more than 2 hours. It may be even the adults. Okay, so now we know that online classes are going on, then remote learning is now gaining popularity. Now this being the case, the limiting the screen time to 2 hours is very, very difficult. Okay, this is a big issue. During the COVID time, again, the condition has been worsened. Now in future we will come out with so many obesity patients as a complication of COVID time. Okay, anyway, another important thing is sugar and sweetened beverages. Now, how much sugar and sweetened beverages he is taking, this will have a definite impact, because sugar and this carbonated drinks and the sweetened beverages, they are one of the triggering factors for obesity. Okay, another is cultural factors. Cultural factors, that means regarding the food, like vegetarian food, non-vegetarian food, etc., or vegetarian. Some people take the eggs daily. So now these are some of the cultural factors regarding the food. If you are purely vegetarian, so chance of in a vegetarian food, to be frank, the chances of obesity is very less. Whereas non-vegetarian food, the chances are more, and any other chicken, mutton, and all those things, the chances is always more. Then meals eaten together as a family. This is another important thing. You have to ask whether the meal has been taken together as a family. All the family members are sitting together and they're taking the meal. This is the old Indian method, and which is one of the beautiful concept. Okay, everybody in the home should sit together and should take the meal at a time. Okay, this now this culture has been disappearing now gradually, and it has been shown that family which eat together tend to less obese than those who eat individually, because the food is equally distributed, everybody is getting the food, and there is no food wastage, and mother is also cooking the food according to the need. Everything is possible by this method. So if now most of the time what happens, either you may overeat or sometimes you may undereat. Most of the time chance of overeating is more when you are taking the food individually by doing some of the work or watching the TV and all. Now ask about the number of takeout meals per week. That means out meals. That means how many times in a week he is going outside for the junk food and fast food and taking the meal. And this history should be also taken in the assessment. Then family activity level. How much activity the whole family is doing. That is also very important. So not only the child's activity, the whole family itself is sedentary family, and they have got 3 4 cars and everything. Servants are there in the home, and the total family activity level itself is very low. Everybody is there, 3 or 4 workers are there to help them. Now this is one more important thing that you have to assess. Then impact of the media. What is the impact of the media? How to what level the family members believe in media? That means advertisement of the media. Okay, different print media, TV media, etc. So, and what is their educational level, and what is their awareness level regarding this advertisement, how much they believe it, how much they blindly follow it, and all these things are very important. Now food messaging and food books, etc. Now See, usually, actually, what happens is marketing starts very early. I want to say that the marketing starts very early. So they aren't the children so much, but what I like to call them as evaluating customers. Now, usually the marketing taxis is technique is also to attract the children. So once you inculcate the habit of this outside food, junk food, packed food in the children, and even in their adolescence and in the adult level also, they become their permanent customers. Okay, this is a marketing technique. So 50% of the ads during the child program, if you see in the TV and electronic media, during the child program, there are so many ads are coming related to this type of foods. 50% of the ads are coming during the child program, so that child is getting influenced and child start now arguing with the mother or to bring that food and like that. So now they send billions and billions of the money for marketing the child food. You just see, so they also play the mind game. So they usually give the advertisement regarding this fast food and all when any of the children's program is telecasted in the TV or any other print medias. So child who is watching it will be get influenced, and slowly now he starts telling her mom, please bring that, like that. And once he get habituated for that, he become a permanent customer for that particular brand of junk food. So this is what actually exactly happening, and all this history has to be taken. Now we have to also assess the assessment of a comorbid factors related with the obesity. It affects from the head to toe. Okay, obesity will going to have number of comorbidity, and it will going to affect obesity of a person or a child. It will going to affect from head to toe. Okay, so one of the main thing is because of obesity is obstructive sleep apnea. Child is sleeping with the open mouth, and there is snoring, and after snoring suddenly the child get up from the sleep and again go into the sleep. So this is obstructive sleep apnea. There will be disturbed sleep. Then second important comorbidity because of obesity is pre-diabetic and diabetic. The child is definitely more prone for either pre-diabetic or diabetic condition. Child is definitely more prone to hypertension in future, hyperlipidemia in future. Child is more prone to non-alcoholic fatty liver disorders in future. Child is more prone to slipped capital femoral epiphysis. This is very important. One of the orthopedic problem because of obesity. Slipped, we will call it as SCFE. Okay, slipped capital femoral epiphysis. This is quite common in the obese children. In obese children, this is quite common. Blunt's disease, one other condition. Pseudotumor cerebri. You may have tumor-like situation, symptoms appearing, tumor in the head like situation, symptoms are appearing like vomiting and all those things. Then precocious puberty, this is one more emerging problem. Obesity also leads to precocious puberty increased chance of polycystic ovarian disorders. Then obesity also leads to depression, low self-esteem, school avoidance, bullying, so whatnot. So there are many comorbidity of the obesity. So always it's better to prevent the obesity rather than treating it. Now, if you see on physical examination, what are the things that we have to see? Vital signs. First, go for the vital signs. Look at the height. Height is important. Weight is important. If the weight is also increased, height is also increased, this is a definite case of a nutritional obesity. Okay, height, weight, then BMI. These are the basic things. Now, BP in the upper and lower limbs using the right size of the cuff is very important. Pulse oximetry, waist and neck circumference has to be taken. These are the parts in the physical examination. Now, obesity children may look normal to you, but when we do the BMI, it may be abnormal. So obesity is not diagnosed by visualizing. So obesity is not just by looking at the child. Okay, so that's what I call nutritional obesity, where height is also more, weight is also more. It is very difficult to pick up this condition. So the best way is go for BMI. Okay, then it is very useful. Otherwise, you will miss many. So you may think that he has got a good personality, but of course he may having BMI more than the requirement because height and weight both are increased now. Dysmorphic features are indicative of syndromes. You look at the obesity, meantime child is also having some of the dysmorphic features. There is some peculiar eye, peculiar ear, peculiar nose, peculiar nasolabial feel, and peculiar eye slanting, etc. So triangular shape of the chin, etc. Okay. Now growth curves are very important, of course, growth curves. So age when the weight gain started, as a baby have got baby adipose fat around 1 to 5 years. later it disappears and child usually lose the weight. This is usually happening after 5 years. Usually the baby loses the weight, because why? Or baby looks very thin. Many mothers complain this. Actually what happens is baby usually contains baby adipose fat, and by 1 to 5 years what happens, this fat will be get dissolved, utilized, and the baby, to some extent, looks very thin. He may be, in height wise, he may be okay, but he looks very thin, and this is quite normal. This is because of the utilization of the baby adipose fat, and it will replaced by the other normal fat. Now, so growth curves gives a correct indication actually from where actually the weight gaining started, what particular age the weight gain started. So then they again start regaining the weight. So the curve will be J-shaped curve. Usually we will get a J shape of the curve. Okay. So first there is more weight, and then around 5 years onwards it suddenly dropped down. Again they start regaining the weight. So we have a J shape of the curve. Okay, so earlier the regaining, if this J-shaped curve, that means regaining of the weight again after losing the baby adipose tissue, if it is start at the earlier part, then it is showing the risk towards obesity. This is how a simply growth charts or growth curves gives the idea. Therefore, growth curves are very, very important. Then we have to also go for head to toe assessment, and then secondary sexual characteristic, because precocious puberty is emerging out as one of the most common comorbidity of obesity. So we have to look into it, especially in female. Okay, of course, precocious puberty in female may be also because of hypothyroidism. Again, there will be obesity, and then mood assessment is very also important, because behavioral changes, psychological changes are quite common in obesity. Okay, maybe because of different social issues and all. So mood assessment should be also understood, examined. Now if you go to the physical examination part, acanthosis nigricans. Acanthosis nigricans is nothing but a black colored strip like structure. You will see acanthosis nigricans is associated with the insulin resistance and metabolic syndromes also. Parents think many times that child is not taking the bath properly. Okay, so see, this is the first picture is showing the acanthosis nigricans. So blackish discoloration with the formation of the rugae and folds, etc. Many times parents think that this is nothing but child is not cleaning the body parts, but it is not so that. Okay, this is called as acanthosis nigricans. So this is one of the important thing which shows that child is getting into the obesity. Of course, this nigricans may be also present in case of insulin resistance and other metabolic syndromes also. Another important finding, physical finding, is gynecomastia. And if you see the second picture here, gynecomastia, abnormal deposition of the fat in the breast area, especially in the male child. Okay, so that is quite evident of developing obesity or overweight, etc. So this is commonly seen by the age of 8 or 9 or 10 years. The child abnormally develop the fat deposit in the chest area or in the mammary area. So especially in the boys, this is quite alarming sign. Okay, another one is the blunt disease of the knee. Blunt disease of the knee, this is actually the disease of the tibia, a shaft of the tibia vera. So that is also one of the common condition. This is the blunt, see. So this is also one of the finding of the initial finding of the obesity. Then stria of the skin, you can see so many stretch marks, as you see in the second picture here. The stretch marks can be seen. Okay, this is called as strays, and this is also indicative of obesity. Then slipped capital femoral epiphysis. The hip is flexed, adducted, and externally rotated. That means a femoral epiphysis is slipped from the acetabular cavity, and this is again quite common in obese children. Okay, adolescents with the obesity. In the X-ray, we find the ice cream falling from a cone-like appearance. Okay, so in this case, slipped epiphyseal femoral epiphysis. So this gives so many differential diagnoses for avascular necrosis of the head of the femur, and then slipped capital femoral epiphysis. These are the common differential diagnoses. In case of slipped capital femoral epiphysis, what the hip is flexed, adducted, and external rotated. Okay, so because of the obesity, the weight gain is there, the weight transfer is there over the hip, and this weight is transferred over the knee, and because of this weight bearing by the knee joint, so this particular medial epiphysis of the the femur is get flexed, adducted, and externally rotated. This is called as slipped capital femoral epiphysis. And these are the pictures that you have shown. See, this is exactly what happens in slipped femoral capitis epiphysis. This is a stable one. Here it is become unstable. Okay, you can, in the X-ray you can find, and this is how the patient knee is flexed, adducted, and externally rotated. Okay, if you see the left one, externally it is rotated, and this is the X-ray finding. The ice cream is falling from the cone. Okay, like that appearance will be seen. Now these are the different growth charts that we are using. Now uh, syndromic obesity and other genetic causes. Now, if you see the assessment part, a clue for the diagnosis is also given by so many factors. For example, onset at birth. Obesity get onset as birth itself, or there is dysmorphic features of the child. The child is hypotonic, especially in you can say Down syndrome, etc. Child is having developmental delay. Child is having stunted growth velocity. So these particular findings in the very early part of the life itself gives a clue that either this particular type of obesity may be genetic or it may be syndromic related. Okay, so now genetically there is some type of obesity is there, familiar hypercholesterolemia. So this is one of the autosomal dominant disorders where the all the family members are having overweight or obesity. Okay, that is one condition. Okay, this is a genetic condition. And further, there is the MC4R gene mutation, melanocortin 4 receptor, was found in 6% of the children with the severe early onset of the obesity. And these patients are usually tall. This is another genetic finding, oncogenic. Okay, so monogenic conditions are there, POMC or leptom gene mutation. These are some of the genetic conditions leading to obesity. Okay, syndromes, as I told, Prader-Willi, Lawrence-Noon, Backward syndrome, Wedman, Alstrom syndromes, even in Down syndrome. So this is quite common. Now, comprehensive metabolic panel, how to go for the lab studies now. So comprehensive metabolic panel and HbA1 to screen for the diabetes, the non-alcoholic fatty liver disease. Then fasting lipid panel should be done, TSH should be assessed, then CBC should be done, comorbidity specific test should be done like polysomnogram, then urine analysis, then dextromethasone suppression test, echocardiogram, etc. According to the comorbidity, you have to go for the different lab studies. Now, these are some of the assessment, physical examination, and diagnosis clues for the obesity. So, with this, we conclude today. In the next class, we will continue the principles of treatment of obesity. So, with this, we stop today. Don't forget to subscribe my channel and also please give your valuable comments. Thank you very much. We will meet again.